Welcome to the Advanced Orthogonal, Axial, and Frontal View Analysis. In our discussion about which X-rays to be taking, we've discussed the analysis of the sagittal and horizontal film, and we also have the frontal and axial views to discuss. Now, the frontal and axial views were taken on the same object to film distance with the same C-arm or L-frame X-ray tube to film distance. Therefore, there's no difference in magnification for the most part. So when we're studying these two films, the size of the anatomy is going to be very similar. And in discussing the axial view, we take it to rule out fractures, genetic anomalies, and pathologies of the C1 and C2 joint space. We also take it to measure the curvature of the superior surface of C2, which we use for calculating our height coordinate in the adjustment. And we also can cross-reference from this film for locating the C2 spinous process and the width of the C6 and C7 vertebrae, so that when we're looking at the frontal X-ray, if we're having a hard time seeing them on the frontal, we can see them more clearly on the axial X-ray and then cross-reference over to the frontal to help find them. The anatomy that we're looking at is the dens, the C2 superior articular facet. So we have the dens here, superior facet or mass here, spinous process here, and the tube angle that we're going to set the axial X-ray at will be from the sagittal view, which we call the axial angle. We preset that into the X-ray tube. We're going to position the patient with their back touching the bucky, taking out head rotation using the chair. We're going to leave head tilt in, and we're going to open the patient's mouth, typically, for the best view of the C2 surface without the teeth or occiput in the way. In order to determine the quality of these films, we need to have no rotation in there, or actually less than 2 millimeters of rotation is our maximum discrepancy. With more rotation, you'll have it not only deviate the location of the C2 spinous for cross-referencing, but you'll also get an obscured view of the curvature of the C2 surface when looking at it from a rotated perspective. In the axial X-ray, we're going to study the axial circles first by clicking on the AO Main Calculations button, called the Cal AO, and that will put a box up on the screen. And then we click on the AO Axial Circle Finder, and we can place 4 dots on the superior portion of the C2 surface, 2 dots on the superior lateral edge, and then 2 dots more medial, as you can see here. Now these dots can also be placed in the traditional analysis, which we'll be discussing, but when you place these 4 dots under the A button with no asterisk, the computer will give its orientation as to what it perceives the circle curvature of the axis to be. You want to place these dots on the superior surface of the axis as frosting on the cake, or marbles sitting on a surface. You don't want it down in the bone structure. You want it barely out on the surface, superior surface of C2. If instead you were to use the A with the asterisk tool, you would still have your 4 dots that you placed, but you would have placed them with the actual dot tool. You then would click on the A asterisk button, and it would put in a template that has all the different curved surfaces, the different diameters of circles on it. And you would slide that template down till one of the lines was superimposing over the outer 2 dots. And then you'd look at the medial dot to see if it was being covered by the same line. If the medial dot was covered by the same line, then whatever axial circle was selected would be the curvature of that surface on that side. If instead the outer 2 dots are covered, but the medial dot is not covered, then that would indicate that that circle curvature is not correct for assessing the curvature of the superior surface of C2. And you would slide this template down, putting a different arced circle onto the outer dots of C2 until the medial dot was covered. Once you've determined what circle each side is, then if it's the same circle all the way through all 4 points, you would press the question mark button, and then it would ask you to input the value for what that overall arc is, which would be the arc that you have designated on your template. If we were to draw the axial circle in the note packet, you would once again put the dots on the outer edge of the C2 surface, right on the outer edge right here and right here, and then you'd come about 1/3 of the way, or 1/4 inch, up the surface of C2 and place a dot in the medial portion on both sides. once again about a 1/4 inch in, about 1/3 of the way up the surface. This basically is showing us the lateral weight-bearing portion of the C1-C2 joint. Now you will have your axial X-ray information and be ready to transpose that axial circle curvature to your frontal film. And that concludes our axial X-ray analysis. Moving on to the frontal X-ray analysis, we take this view to assess the biomechanics of the misalignments. This helps us to understand our influences and our proper table placement procedure. And we also measure the exact line of drive required to realign the cervical spine. We're going to cross-reference this with the other views to locate the atlas transverse process. And once again, we took information from the axial film to bring over to our frontal film. It is also intriguing to think about that on the frontal view, as well as the horizontal view and sagittal, we're going to be measuring the patient's genetic anomalies and uniquenesses in their upper cervical spine as well. And when we're looking at the anatomy to get our bearings of what we're marking, first we're going to be marking the temporal parietal suture. We're going to be outlining the eye orbits, and we're going to be looking at the eye orbits to the side of the head, and we looked at that in our X-ray placement protocol to see if the skull was rotated as the patient was positioned. We also want to recognize the curvature of the mastoids and the location and height of the mastoids compared to the condyles. We also are going to want to mark the condyles, the outer edge, as well as the dots. We're going to recognize the atlas posterior arch and the transverse processes. And we're going to look at the C2 surface body as well as spinous. We're also going to identify the sides of the C7 body. And remember, when we took the frontal X-ray, we had positioned the patient where the bucky was tilted to match their posture after we had set the X-ray tube to this ASP, which is the atlas sagittal plane line. We're going to position the patient where their back is touching the bucky and their occiput as well. We're going to remove head rotation by looking at the lateral canthus of the eye, or a lateral edge of the eye out to the side of the head, and look for symmetry there. And if it wasn't symmetrical, we rotated the chair till it was symmetrical. And then we knew we were not leaving head rotation on this film. We did leave postural head tilt. We did not try to upright the patient any further than their vertical posture would let them go. And then we put the head clamps over the C1 region to help center and stabilize the patient for the film. And remember, when we looked at the eye orbits to the side of the head, the lateral canthus, we could see on the film that where the frontal bone and temporal bone have this line demarking the interface of the two, and it comes down and joins the eye orbit, it forms a little X. And we discussed looking at the widths of the spacing to see if they're symmetrical. And if the patient was left rotated, well, they look right rotated, but if the rotation was not eliminated, then you would look at the frontal X-ray and you would see the spacing is not symmetrical. We also talked about seeing where the cheekbone would overlie the mastoid on each side symmetrically if there was no rotation, but if there was rotation that was not accounted for in the placement, then the cheekbone would overlie the mastoid further than on the other side. And we also discussed the nasal cavity approximating the side of the C1 mass. We discussed the X-ray quality was not having any more than 2 millimeters of rotation of the head in the eye orbit assessment heading out, and the zygomatic connection to the mastoids. The nasal cavity was our least reliable because remember that's a skull nasal cavity compared to the C1 vertebrae, so it's our only feature we mentioned that is not a skull-to-skull reference. Therefore, it's less reliable. We do need to be able to visualize the condylar surfaces here and here, and we need to be able to see the entire atlas. When we're studying for the atlas frontal plane reference, so this is the plane of the atlas on the frontal film, we do have to factor in genetic anomalies. When we factor in genetics, we have to look for which aspects of the atlas are the best fit for the overall bone structure reference. So if we were to draw a line on the top of the superior tips of the atlas, and draw a line through the inferior tips of the atlas, and draw a line through the inferior attachment of the posterior arch to the lateral mass, and the superior attachment of the posterior arch to the lateral mass, we would have 4 reference points of the atlas. We could compare each of those to see how well they agree on the plane of reference for the atlas bone. if they all were on the same plane approximately, then we would have, in this example, 3 out of the 4 lines are in complete plane reference agreement. 1 is a slight bit off, which happens to be the inferior masses. So that would tell us that the inferior tips of the atlas are not symmetrical with the rest of the bone structure, and therefore the inferior tips of the atlas would not be a good reference to choose as the most consistent line of reference for this atlas bone. And in this example, we would have selected the inferior aspect of the posterior arch attaching to the lateral aspect of the lateral mass as our most consistent point of reference on this patient's atlas. So here we have another patient. And this patient, if we were to have our same lines of reference, you would see that the right lateral mass here is very, very tall compared to the left one. Now, that's often a genetic asymmetry where the C2 surface on this side would develop lower and the condyle would develop higher. But nonetheless, the superior and inferior surfaces are in total disagreement, and yet the arch represents a more fair bone assessment of the average structure of the atlas. Both the superior and inferior arch attachments to the lateral mass seem to be in relatively good agreement, and therefore we could use either one of those as our primary reference. And with the Grostic-based procedure, almost always selecting the posterior arch inferior surface attachment to the lateral mass, then we would have been able to select that as an accurate reference of this patient as well. Here we have an atlas that is the third atlas in reference to our anatomy, and it has 4 different references. It has a superior and inferior tips, has a superior arch attachment, and those 3 are in agreement when we look at the comparison. But the inferior arch does not agree with the other 3. The reason for that is if you look at the structure here, the height of the right arch is much wider compared to the height of the left arch, and therefore the inferior arch attachment spot is completely inconsistent with the rest of the bone and could not be used as our consistent point of reference for this atlas. In this example, we could actually use either of the other 3, but the posterior arch inferior attachment would be inconsistent. And what we would choose to use is the one point on the atlas of most clarity on the film. We could use the inferior tips or the superior aspect of the arch. When we look at the next aspect of analysis, this is where we take the frontal template and we're going to line it up on the skull, looking for what is the overall best fit on the skull to begin with. And you can see here that on the first example, we have a center line of the template with these arc lines trying to match up to the skull, and the first arc line is hitting the side of the skull, but the first arc line here is not. Second line is. Therefore, this template is not generally lined up to begin with. This template is angled way too much, and this template is most consistently aligned with the skull in our general first perspective. So once again, number 1 is shifted to the left, number 2 was too rotated, number 3 was just right. When we pursue what's called the zoning procedure, we have the A line and B line and C and D and E line on the template, which is our horizontal lines indicating the height of each zone. We have the curvilinear lines on the outside where we have hash mark lines as well as consistent curved lines. And then we have these individual ticks and triangles in between to give us closer referencing to the side of the skull. The AB zone will be considered our primary zone of reference, with the BC, CD, and DE zones being secondary zones that we'll use to confirm our AB zone to be accurate. We're going to use these zones to find the symmetry of the skull within each zone and compare the right and left sides, looking for consistently aligning one mark on the left side of the template and one mark on the right side of the template to the skull, and then doing that on the B line to align our AB zone. And here you can see the zones that we'll be referencing and the lines that we'll be using. First thing we'll do is we're going to mark the temporoparietal sutures on each side. We're then going to click on the Cal AO button and place the AO main calculations box on the screen. We're then going to put our template on and visually line it up as best we can where the A line is sitting on the highest suture. So you can see here that it's sitting quite a bit above the suture. And we're going to line the template up where it's actually sitting on the suture. The A line is sitting on the highest suture. And then we're going to use the greater than, less than symbols to rotate the template, or the minus and plus symbols to change the size of the template to help it match the skull. We're then going to, once we have it match the skull, we're going to slide it down to the next zone where we'll now put the B line on the suture and do the same matching up, either using the greater than and less than symbols to rotate it, or the plus and minus to enlarge and shrink it. We're going to then do this to get the BC zone marks to match up. And once they match up on both sides, where the C marks on each side match and the B marks on each side match, then we'll have the BC zone telling us that that is its best perspective of that same zoned area. If that happens to match up with the AB zone's designation of what it considered the center mark for this skull, then we have two zones that would be in agreement, and that would give us extra confirmation that the skull line we will draw on the frontal X-ray, which is called the frontal cephalic line, is consistent for that area of the skull. And when we press the question mark button, the computer will then drop the vertical line through that center mark of the skull's weight, and it will reference everything else to that line. When you remember when we just discussed the best fit for the atlas, when we discussed looking at all four reference points and then deciding which one was the most consistent, then we would click on the button that would tell us how to put the dots simply on the one point of atlas reference that we found to be most consistent. And we would have a left and a right dot placed with the AFP button. Once we've clicked that AFP button and placed the dots on our points on the atlas, then we will need to take these little X's right here and here, and we'll need to grab that and drag that to the center to outer width of the mandible at that level. In the next step of the analysis, we're going to analyze the cervical spine and spinous rotation, and we will click on a button that says AO axis spinous process, and then we are going to mark the anatomy in the following order. We're going to first click on the left side of the dens where the indentation or the concavity occurs, and on the right side of the dens. We're then going to click on the tip of the C2 spinous process. We're then going to mark the lateral body of C7 on both sides. Those are the 5 marks that we make, and once we've made those marks, the computer will scribe the line going through the cervical spine, and it will often give us a vertical line from C7 as well. That can tell us how off-centered they are from their vertical plane of reference. Our next step is to click on the AO condyle circle finder, and there's 2 ways that this is done, just as it was on the axial X-ray. If you click on the AO condyle circle finder, you would place your dot on the outer aspects of the condyles, where the curvature of the condyles joins the lateral border of the condyles, and you'd place a dot on the surface of it as icing on the cake or a marble on the surface of a table. And you would do that on the left side, and then you would do that on the right side. And then you would come about 1/4 of an inch down the surface of the condyle, which is about 1/3 of the distance, and you'd put another dot right on the surface, and then you'd come and do that on the right side as well. Right here. The computer will then give you its best reference as to what it perceives the curvature of the condyles to be. So here you can see the 4 dots placed, and the computer would tell you its reference. And this is the button that would have been pushed in order to initiate the 4 dots being placed and the computer giving you its reference. However, the primary way that the condylar circles have been referenced is by clicking on the dot button and placing the 4 dots on the surface as described before, putting a dot on the outer edge of the condyle on both sides, and then 1/4 of an inch down, which is 1/3 of the distance. And having those 4 dots there, when you click on the button that is the C with an asterisk, it will put these arced line templates on here, and you would slide the template till the template covered the outer 2 dots on the surface of the condyle. Then you would look at the medial dot and see if the same line that was covering the outer 2 dots was now covering one of the medial dots. If it's not, then you would slide the template to the next line till you found the medial dot being covered by the template as well as the outer 2. And as soon as the template is covering the medial dot, you know that the arcs on the template are now representing the curvature of the condyle on that side. If on the other side the medial dot is also being covered, then you know that that arc line represents the curvature of the condyles on both sides and is a consistent aspect of anatomy with noted genetic anomalies between the 2 condyles. If the condyles are not in agreement from side to side in regards to how curved they are, this would indicate a genetic anomaly of asymmetry between one curved side and the other curved side, and you would accommodate for that in the overall adjusting procedure by measuring the curvature on the one side, measuring it on the other side, and then taking the average of those 2 as the overall curvature integrity of the condylar to mass relationship. And once you've determined what your final answer is going to be, you press the question mark button, and it will pull up a box in which you will type in what the arc number is that you determined. For analyzing for aberrancy in the condylar superior vertical plane, we're going to place the same dot that we have on the outer aspects of the condyles, and then we're going to click on the AO cervical aberrancy tool. Using the marked spots, which means when we look at this aberrancy tool, we have these curves here that are designed to fit on the condyles, and we have these little demarcations on the template which are equal distance from the center of the template itself. And we're going to bring the template down and set the arc on the condyles, centering it to the outer 2 dots. And we're going to center it to the points on the template that are in agreement. So you can see here this dot, for example, is sitting just inside the number 3 tick on each side. So the aberrancy template would be aligned to the perspective of the condyles. We're then going to drag the template up to the area above the sutures, and the computer itself is going to keep the template on the same plane of reference unless you press the greater than or less than symbols to try to rotate the template. But you would have already done that down at this point when you were aligning it to the condyles. We're then going to slide the template side to side using the mouse on the little center point of the template. And we're going to look at the right side to see how the lateral curvilinear line matches the side of the skull in the area that we zoned on the right, and you're going to determine what that number is. So it's a 3 line that best matches the skull from the condyle's perspective on the right hand side. You're going to make a note of that number, and then you're going to slide the template to the other side. And in this example, you can see that the condyles view the left side of the skull on a different plane of reference, so it's a number 4 on the left hand side. And we would make a note of that number. We're going to calculate the change between these two as to how the condyles view the area that we zoned previously by subtracting whatever number you have on the right from the number on the left. So it's the left number minus the right number, and then we're going to multiply that times 2. So here we have a 4 minus a 3 gives us a 1, and then we're going to multiply that times 2, and that will give us a 2-degree discrepancy in how the condyles are planed compared to the center line of the parietal bones. So when we press the question mark button, we would then put a 2 into the box here, then press OK, and the computer would input the aberrancy of the condyles into our overall analysis. And our next step is to add the axial circle from the axial film into this study, And how we do that is we'll just click on the AO axial circle template, put it on the screen, press the question mark button after you touch the center spot here of the template. And when you press the question mark button, it'll put the little box up and you'll type in what that number was. And in regards to putting the AHRY in there, we'll be discussing that in our next slide, where you've got your box of information sitting here, and you're going to double click the mouse, double click it on the main calculations box. And when you do that, a box is going to pop up that looks like this. And it'll ask you, what is your pre-Y? And that is the measurement that you took from your horizontal film, and you're going to type it in here. And now it's going to add in the pre-Y as well as give you the Z and Y coordinates for the instrument setting. Now keep in mind that because the instrument sets on a Z-axis and on an X-axis, that this Y vector is actually an X vector. But these are going to be your two instrument settings you'll be taking into the adjusting room to put into the instrument. So for practice, we're going to want you to draw in your note packet the following information. You're going to want to draw in the FCL and the AFP and the spinous and the cervical spine line. So you'll want to draw that in, and it will end up looking something like this. Frontal cephalic line bisecting the skull, AFP going through the structure of the atlas that's the most genetically constant, a dot on the tip of the C2 spinous, and your other dots that you put when you had done your analysis, where you have a left dot on the dens, right dot on the dens, dot at the tip of the spinous, dot on the left cervical spine, and dot on the right cervical spine body. And there you have the frontal analysis completed in order to be able to take the coordinates in the adjusting room and know that you've got the right mathematics from which to now calibrate for a proper correction.